Uh, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome on board, all colleagues. And in the last week, 30th week and last week of Anesthesia and Critical Care refresher course by Saving Lives Academy. It's a very short introduction. I am sure and I trust that you're all familiar with every single guest speaker of the panel. Uh, Dr. Amr Hashim is a consultant anesthesia, consultant cardiothoracic, adult and pediatric anesthesia in Alexandria University, is currently working as a consultant of cardiothoracic anesthesia and adult and pediatric in Freeman Hospital in United Kingdom. So the topic of tonight is acute coronary syndrome. Uh, Before we finish, so it's just one lecture tonight, then we will have to meet all the speakers or whoever available from our guest speakers, delivering their thoughts about the course in the last 6 months. My full appreciation to your presence over the last 6 months, and everything will stay recorded on savinglivesacademy.com. There's no worry about this one, it will stay always for free. And at the end of this session and after the discussion, I beg your pardon that I will take the discussion in Arabic to represent ourselves more freely. So if we have any non-Arabic speakers, you are welcome to attend this lecture and the discussion after the lecture, but we will be talking in Arabic after that to close and celebrate the finishing of the course. So thanks, and the mic to yourself, Dr. Amr Hashim, and your topic, acute coronary syndrome. If you are
Thank you
unmute.
so
So,
much. Thank you very much, Dr. Walid. I'm very honored and blessed to be part of this amazing course, and very honored and blessed to be the last speaker as well. So I'll start with my presentation today with the acute coronary syndrome, and I would like to thank all our colleagues and panelists and all the attendees beforehand and hopefully after the session as well. So from the acute coronary syndrome, there is no conflict of interest from my side. And from the outlines, I will be discussing the definition, pathophysiology, management, differential diagnosis, guidelines, and some acute coronary syndrome tips in case of COVID-19. The following references are very nice ones, which I used 2017 acute MI in patients presenting with ST elevation, European Society of Cardiology, 2020 acute coronary syndromes in patients presenting without persistent ST elevation, and European Society of Cardiology as well. And the last one is the Institute of Cardiology Guidance for Diagnosis and Management of Cardiovascular Disease during the COVID-19 pandemic. So what's meant by the acute coronary syndrome? This refers to a spectrum of clinical presentations ranging from ST elevation MI, STEMI, non-ST elevation MI, non-STEMI, or NSTEMI, and unstable angina. It is almost always associated with rupture of an atherosclerotic plaque and partial or complete thrombosis of infarct-related artery. This is an important terminology, IRA, or the infarct-related artery, which is the zone of infarction related to the artery which is obstructed. And what's meant by unstable angina? It is an ischemic type of chest pain, which is usually of recent onset, more frequent or severe or prolonged than the patient's usual angina, and is more difficult to control with drugs, or is occurring at rest or on minimal or in minimal exertion. And cardiac biomarkers in this case are not elevated. Myocardial infarction, these are ischemic symptoms, which is evidence of raised cardiac biomarkers, and the acute MI or AMI may be further categorized as STEMI or non-STEMI, as we said. STEMI with ST elevation on subsequent 12 ECG leads, non-STEMI with ST non-elevation on the 12 leads ECG. What are the clinical classification of different types of myocardial infarction? So this is clinical classification, type 1, 2, 3, 4, A, B, and type 5. Type 1, 2 are the most important. Type 1, which is spontaneous myocardial infarction, which is related to ischemia due to primary coronary event, such as plaque erosion or rupture, fissuring, or dissection. Type 2, so this is mainly the pathology is related to the coronary artery here. Type 2 is infarction secondary to ischemia, either increased oxygen demand or decreased supply. For example, coronary artery spasm, anemia, arrhythmias, or hypotension. All of this cause decreased supply. And if they are coupled with increased demand as well, such as sepsis or infection or exercise or anything, this is going to be a myocardial infarction, which is type 2. Type 3 is sudden unexpected cardiac death, and this is usually attributed to a coronary artery event. Type 4A is a myocardial infarction associated with PCI, so happening during the PCI event. And 4B is myocardial infarction which is associated with in-stent thrombosis as documented by angiography or autopsy. So these 4A and 4B are both related to the PCI and stents. Type 5 is related to surgery or CABG or CABG myocardial infarction. So these are the 4 types. What is the pathophysiology then? So there's always an atherosclerotic plaque which is composed of lipid core and includes cholesterol, oxidized low density lipoprotein, macrophages, smooth muscles, and covered by a fibrous cap. And this plaque, when they become plaque, they become vulnerable plaques. It's often rich in lipid covered by a thin fibrin cap, and this plaque, when it ruptures or fissures, exposes a thrombogenic lipid and the collagen, which are potent activators of platelets, and plaque erosion activates coagulation pathway as well, and also activates the adherence of platelets. So as we can see here, this is the lipid-rich necrotic core, and this is the needles for the thing, and this is the fibrous cap here. And when this plaque ruptures, or there is rupture of the endothelium, which is already distended with inflammation, accumulation of lipids, and thrombus is formed on top by adhesion of platelets, and then activation of the coagulation cascade, which will definitely ultimately occlude the lumen if it continues like this. So the inflammatory process here is an important role in rendering plaques vulnerable to rupture, as they both activate metalloproteinases that degrade collagen in the fibrous cap and inhibit synthesis of new collagen. And lipid-lowering agents such as statins may stabilize plaque not only by lowering the cholesterol, but also by having an anti-inflammatory effects, and this is very important for these drugs. So as we said, there is always a platelet adherence and then platelet aggregation, which is the white thrombus, followed by a complete thrombus formation by activation of the coagulation process, which is then turned to red thrombus. So white thrombus is initially formed, platelet accumulation, and it's inhibited by antiplatelets. And the white thrombus, as I said, which is rich in platelet, is always inhibited by COX inhibitors such as aspirin, ADP receptors mediated blockers such as clopidogrel, or G2B3A receptors such as tirofiban. And then it follows by the red thrombus, which is activation of the coagulation pathway, leading to exposed activation pathway by the exposed lipid and fibrin, and as well as by the new platelets which are activated, and ultimately forming the thrombin activation and laying down of fibrin clots. So this is fibrin clot. And why it is called red? Because red cells are enmeshed in this fibrin clot. So it is called red thrombus clot or complex. And this surrounds the white thrombus. So sudden artery occlusion will then follow by this thrombus and complicated, and then a vessel vasoconstriction or spasm may also increase the impact of ischemia. So what's the treatment of red thrombus? It's always antifibrin. It's not here platelets, it is fibrin. So fibrinolytic agents or antithrombin therapy are the treatment of these fibrinolytic agents such as the streptokinase and the new generations, and the anti-thrombin therapy such as the heparin or the other low molecular weight heparin medications. So this, as we can see here, so this is the black, and this is the white thrombus from platelets, and this is the red thrombus fibrin and enmeshed red cells, and this is occlusion here, which is usually by the red thrombus. And this is the difference between a hemostatic plug and the thrombosis. So hemostatic plug, if there is injury to the vessel, it usually heals the sides of the vessel, but it does not occlude. This is different from the plaque here, which ruptures, and this is the thrombus inside, which occludes the vessel. And this pathophysiology is usually correlated with the presenting syndrome. So STEMI, for example, is generally due to local occlusion of the artery by a superimposed vulnerable plaque, which leads to myocardial damage in its area, and the extent of loss of muscle tissue may be reduced by restoration of coronary flow. While the NSTEMI and unstable angina are usually caused by an imbalance between the oxygen supply and demand, which is here the vessel is not totally or completely occluded. So thus increasing the demand or decreasing the supply more will lead to the NSTEMI or unstable angina. What is the differential diagnosis of the acute coronary syndrome? There are cardiac causes, pulmonary causes, vascular causes. Cardiac causes such as myopericarditis, cardiomyopathies, tachyarrhythmias, acute heart failure, hypertensive emergencies, aortic valve stenosis, Takotsubo cardiomyopathy, and coronary spasm. There is pulmonary, such as pulmonary embolism, tension pneumothorax, bronchitis, pneumonia, pleuritis, vascular, such as aortic dissection, which is very important for differential diagnosis, symptomatic aortic aneurysm, stroke, GI, especially important in the RCE territory infarction, which is always presented by epigastric pain. So we have esophagitis, reflux or spasm, peptic ulcer, gastritis, pancreatitis, cholecystitis, and the orthopedic such as musculoskeletal disorders or trauma, and others, anxiety, herpes zoster, and anemia, all are differential diagnoses. Most important, aortic dissection, pericarditis, and the pulmonary embolus. Conditions other than acute MI type 1, which are associated with biomarkers or troponin elevation, such as tachyarrhythmias, heart failure, hypertensive emergencies, critical illness like shock, sepsis, burns, myocarditis, Takotsubo, structural heart disease such as aortic stenosis, aortic dissection, pulmonary embolism, and hypertension, renal dysfunction, very important, and associated cardiac disease, coronary spasm, acute neurological event such as a stroke or subarachnoid hemorrhage, cardiac contusion, hypo or hypothyroidism, infiltrative diseases, myocardial toxicity, drug toxicity or poisoning, and rhabdomyolysis. So not all the cases with elevated troponin are MI. Risk stratification is very important. So when this patient comes with acute coronary syndrome, can we do a risk stratification and triaging for him? Yes. How come? By history, physical examination, ECG, cardiac enzymes, and sometimes we need to do echocardiography if the whole picture is not very well obvious or clear. Diagnosis is formed as a STEMI, and STEMI is depression suppression for acute ischemia, non-coronary chest pain or stable angina, and a stable angina for outpatient treatment, and we can classify this from the risk stratification and the triage of the patient. Immediate evaluation of the patient by blood pressure measurement, pulse oximetry, continuous ECG monitoring. Immediate action is a 12-lead ECG within 5 minutes of arrival, oxygen via face mask or nasal cannula, venous access to draw cardiac biomarkers, biochemical and hematological workup if needed, if possible. And immediate action is to give analgesia, offer oxygen and nitroglycerin to decrease the preload and increase the supply, decrease the anxiety by reassurance, and if not, administer small incremental boluses of intravenous morphine, 1 to 2 milligrams, very good management of analgesia and decrease the anxiety as well. Aspirin immediately and sublingual nitroglycerin, as we said, and sublingual nitroglycerin may have some side effects, so it's avoided in cases of hypotensive patients and may itself cause hypotensive reactions or hypotensive bradycardia response due to basal gyrus reflex, which is the decrease in heart rate due to ischemia of the myocardium. The clopidogrel, which is the to be in the orange, it should may be considered, and 3, it is not recommended always in red. And this is accompanied by level of evidence A, B, and C according to the level of evidence for these trials. As we can see here, this is from the European Study Guidelines for the management of these patients at presentation. So here, clinical setting, symptoms, and vital signs. Is it either low, MI, or high is the classification. And this is according to certain clinical settings and criteria. So in high, for example, likely is this patient comes in CPR or in shock, and low is just some normal inconclusive chest pain. ECG is very important. Here there is normal ECG, and here there is ST depression, which is maybe mild or maybe a severe ST depression or ST elevation. And this is the ECG findings that we do for the patient. Then, as we said, we draw biomarkers such as troponin level, and this is at 0 hours at arrival at the clinical setting, and 1 hour later, 2 hours, or 3 hours according to the protocol. So some centers use 0 and 1 hour, or 0, 2 hours, or 0, 3 hours, and compare the troponin levels increase or decrease or the same. And according to this, they can categorize the patient. And if so, here, if the troponin level, for example, is not present at 0 hours, and here the change is not present in 1 or 2 or 3 hours, so we can, with this normal ECG or some ST depression or mild depression and the negative troponin, we can rule out rule out MI or myocardial infarction, and this is the triage decision for this patient. But if positive or negative troponin, but ST depression is still, and they observe this patient, and later on we can rule out MI or rule in MI by NSTEMI or STEMI, or go to a patient with the unstable angina or other cardiac disease. ST elevation is very important, and according to the troponin level, here and the degree of troponin according to the elevation and the presentation, and the follow-up at 1, 2, or 3 hours, as we said, is it the same or is it increasing? And with this, we can rule in MI for this patient. This patient should be ruled in if they have a severe ST depression or ST elevation with increasing or changing or initially high troponin levels. This is from the most recent guidelines, 2020 European Society of Cardiology. So STEMI patients presenting with to hospital with for PCI, this is important. And if this patient is for PCI, the hospital should be capable of doing this and should be done within 90 minutes of the first medical contact. If the patient is presenting to hospital without cath lab or without PCI capability and cannot be transferred to PCI center for intervention within 90 minutes from first medical contact, and this should be treated with fibrinolytic therapy within 10 minutes, the new guidelines from the first medical appearance. But if this patient is in a hospital with a capability of transferring the patient in less than this time to another center with a capability for PCI, so he should go for PCI. Patients who have received thrombolytic therapy should be considered for transfer to a PCI capable center depending on the risk profile. So if this patient had thrombolytic therapy and still are high risk patients, as we will know later, they should be still transferred to a PCI capable center after that. And this was the things, the guidelines in 2017 for the STEMI, as there was a clear definition for the first medical contact, definition of the zero time for the reperfusion as being the strategy and the start of the clock time for the STEMI diagnosis, and selection of PCI over fibrinolysis, as we said, door to balloon term eliminated from the guidelines. What is the first medical contact? First medical contact is the time point when the patient is either initially assessed by a physician or a paramedic or nurse or other trained emergency medical service personnel who can obtain and interpret ECG and deliver initial interventions such as defibrillation, for example. So all the paramedics are considered a first medical contact. STEMI diagnosis, the time at which ECG of the patient with ischemic symptoms is interpreted, which is presenting the ST segment elevation or equivalent. So STEMI is always by the ST elevation done. So this is the time of the diagnosis. Primary PCI, as we said, emergent without PCI with balloon or stent or other approved device performed in the IRA or the infarct-related artery without previous fibrinolytic treatment. Primary PCI strategy, this is an emergency coronary angiography and PCI in the IRA if indicated. What is meant by rescue PCI? Because we sometimes come across through these terminologies and we don't know what's meant by them. This is usually, we as critical care doctors or personnel are usually on call from the coronary care units or from the out of hospital cardiac arrests or from our cardiology colleagues, and they usually use these terminologies if they want to have our opinion or assessment of any of their cases in the units in CCU or in the ward, or even if this patient is coming to cath lab directly after an out-of-hospital cardiac arrest. So one of these terms is rescue PCI, which is an emergent PCI performed as soon as possible in the case of failed fibrinolytic therapy. So this patient has already failed the fibrinolytic therapy and is coming for a PCI. Routinely, early PCI strategy after fibrinolysis, as we said, this is between 2 and 24 hours after successful fibrinolysis, and this is in high-risk patients, as we mentioned before. What is the pharmacoinvasive strategy? This is fibrinolysis, which is combined with rescue PCI in case of failure, or routine early PCI in case of successful fibrinolysis. This is a flow chart for the modes of the patient presentation and the components of the ischemic time, and how we flow chart how is the pathway for reperfusion strategy selection in these patients. So the patient has already the chest pain here, and if he contacts the EMS directly, so the first medical contact will be the EMS, and in less than 10 minutes there will be in a center which can diagnose, so ECG can be done even in the ambulance with a STEMI diagnosis, and we can calculate the time from that time if these pictures or ECGs are sent to the hospital. And in less than 120 minutes, we can go for primary PCI strategy, the distance, and less than 90 minutes, so the perfusion should be there with a wire crossing the infarct-related artery. This is the first presentation. The second, if this patient's first medical contact is a non-PCI centers. So he goes to these non-PCI centers, have a diagnosis of STEMI by ECG, and then if still the time is less than 120 minutes, it will have the same pathway for reperfusion primary PCI strategy. But if the distance for this center should take more than 120 minutes, so we should do the fibrinolysis strategy in less than 10 minutes of initial contact with the hospital. And the third mode of patient presentation or the first medical contact is a PCI center. So already comes to a PCI center immediately, and in less than 10 minutes, he should have a STEMI diagnosis, primary PCI. In less than 60 minutes, he should have his reperfusion with wire crossing the infarct area. And these are the reperfusion strategies in the infarct-related artery according to the first symptoms. So as we said before, between 0 and 3 hours and up till 12 hours, there is the early phase of STEMI in the first 12 hours. In the first 3 hours, better, which is the primary PCI, is 1A, and the fibrinolysis is 1A if it is more than 120 minutes from the PCI center, as we said. Between 3 and 12 hours, also primary PCI is 1E, and the fibrinolysis if there is a delay in the transportation. After 12 hours, between 12 and 48 hours, this is the evolved STEMI phase, where we have still primary PCI if symptoms or hemodynamic instability or arrhythmia. So if these issues are still there, we should go for a primary PCI with class 1C of recommendation. But if this patient is asymptomatic or stable, this is class 2A, the primary PCI is class 2A, between 12 and 48 hours. After 48 hours, there is still the patient in a phase which is called recent MI, recent STEMI, and with this recent STEMI, he's still a candidate for a primary PCI if he's unstable, but if he is stable, no way to do any routine PCI in these asymptomatic patients after 48 hours and the patient is stable. And as we said here, the absence of ST segment elevation, primary PCI strategy is indicated in patients with suspected ongoing symptoms, as we said before, such as hemodynamic stability, recurrent ongoing chest pain, life-threatening arrhythmias or cardiac arrest, mechanical complications of myocardial infarction, acute heart failure, and the recurrent dynamic ST segment or T wave changes. Around the procedure, very important is the use of antiplatelet therapy, peri-procedure and the post-procedure in these patients. So usually a potent P2Y2, which is a portion of the ADP receptor, is given to these patients, plus 1A, which is prasugrel or ticagrelol or clopidogrel. But the recent studies has showed that the prasugrel and ticagrelol have more reliable and less incidence of thrombosis than the clopidogrel. Aspirin, as usual, if it is given oral, if the patient is conscious. If he's not conscious and have NG, put it through the NG. If the patient is not, you can give IV or PR in sometimes, but it is usually the class 1B recommendation. Class 2B, 3A is as tirofiban, and these medications are usually used if the patient presents initially to the cath lab without administration of any of antiplatelets, and there is no NG, the patient hasn't any aspirin, for example, and he is going for cath lab, and in this situation, we give him the tirofiban bolus and then infusion dose, and we give him heparin and then go for the cath lab or catheterization. Cancarillor may be considered in patients who haven't received these P2Y2 receptor inhibitors, which is because this drug can be given by intravenous route, and is class 2B as well. Anticoagulation, other than the antiplatelets, is recommended for all patients in addition to antiplatelet therapy during the primary PCI. We usually give heparin in the form of 100 units per kg and do an ACT to make sure of the level. Routine use of unfractionated heparin is recommended if this is the case, and if the patient has hit for any reason, we can use the bivalirudin, which is anti 2A factor, and this is the recommended thing if this patient has hit. Routine use of enoxaparin should be considered. Routine use of bivalirudin should be considered, and fondaparinux is not recommended for any primary PCI, and this is very important. It doesn't cause hit or very low incidence, but it is not recommended for primary PCI. In case of the, don't forget in these patients that in patients presenting with a STEMI for primary PCI strategy, this is usually the first 24 hours hospital admission. So we, after the PCI, is either considered transfer back to the non-PCI center, okay? And don't forget about the high dose statin or beta blockers. And if the ejection fraction is less than 40% or in heart failure, or if the ejection fraction is more than 40% with no heart failure, this is grade 1A, and this is 2A. In the non-IRA PCI, it is classified as 2E. ACE inhibitor is very important, especially if the patient ejection fraction is less than 40% with heart failure, it is 1A, and if it's more than 40% with no heart failure, it is 2A. Sorry, I passed one of the slides here. So again, the strategy for the STEMI here is from the first presentation to the presentation from 0 o'clock is a STEMI diagnosis, do ECG monitoring, alert the cath lab, and the bypass the emergency department. So if you are in the paramedics in the hospital, in the ambulance, for example, and they do ECG monitoring, and they bypass this any emergency department, to go directly to the hospitals with cath lab, and then do the aspirin loading if the patient is awake or have an NG, and sometimes give prasugrel or ticagrelor loading as well, and oxygen therapy if the saturation is less than 90%. Previously, in the previous guidelines, it was 95, but now less than 90%, aiming for 95%. If this patient is needs a rate control, you can give beta blocker or opioids or tranquilizers for this patient. And as we said, at 90 minutes, the wire should be crossing for reperfusion of the artery through radial access. This is the recommendation now, better than the femoral because of less bleeding and less complications. And at that point, we give unfractionated heparin immediately before that, and then we, according to the strategy of the or the protocol, we might use the grade 2B 3A blockers, such as the tirofiban bolus or infusion, especially if the patient hasn't had any prasugrel or ticagrelor previously. And then we put the new generation dual drug-eluting stents. This is the new generation, is the recommendation now. Then we pass this period to the other 24 hours, which is I mentioned before. You can transfer the patient back to PCI center, give him high-dose statin, beta blockers, ACE inhibitors, and after that, routine echo that aspirin and the prasugrel or ticagrelol, which are better than clopidogrel now. And if this patient is still suffering from symptoms of heart failure, we can do MRI or MRA if the ejection fraction is low, to see if there is any viability of the myocardium and the possibility for doing more interventions for full revascularization of the patients. So this patient is either, as we said, for primary PCI or fibrinolysis. If the center is not equipped by a cath lab and the transfer period is more than 2 hours, you should give the fibrinolysis and the fibrinolytic agent according to your guidelines, as we said. So if the patient is presenting in left ventricular dysfunction or acute heart failure with this ST elevation, what should we do? ACE inhibitor is very important, or ARB if not tolerated, especially if the ejection fraction is less than 40%. Beta blockers, as we said, in patients with ejection fraction less than or equal 40%, and or heart failure, but after stabilization, not in the acute stage. We shouldn't give these medications in the acute stage of pulmonary edema or heart failure. MRA, as we mentioned before, to quantify the rate of the viable myocardium. Loop diuretics are important for these patients as well. Nitrates is recommended, oxygen if less than 90%, and intubation if needed if it is aortic arrest with low Glasgow scale or respiratory failure or showing any signs of hypoxemia, hypercapnia, or acidosis, and non-invasive positive pressure ventilation if the saturation is less than 90% and the patient can tolerate it without intubation. Opiates, as we said, and inotropic agents are indicated in severe heart patient failure with hypotension, refractory to standard medical therapy, and the pulmonary edema. We can use the inotropes. What's the management of the cardiogenic shock in this patient? As we said, this immediate PCI for this patient. So a patient in cardiogenic shock is a very good candidate, is the best candidate for this PCI. For all patients in cardiogenic shock, if the anatomy is suitable. But if the coronary anatomy is not suitable, emergency CABG or emergency CABG. Invasive blood pressure monitoring, immediate Doppler echo to quantify the lesions, valvular lesions, and the complications, mechanical and loading conditions, preload and afterload, and detect any mechanical complications. And it is indicated that mechanical complications are treated as early as possible after discussion with the heart team. Oxygen or mechanical respiratory support is also indicated according to the blood tests. So ultrafiltration in this patient is congested and have some renal impairment as well, or AKI should be put for ultrafiltration. We can use inotropes or vasopressors in hemodynamically unstable patients. And we can use also the new thing, we can use shorter term mechanical support in patients with refractory shock, such as intra-aortic balloon pumps or impeller devices, or even sometimes we can use the VA ECMO as a temporary to recovery for the candidate patients. But is routine intra-aortic balloon pump indicated? No, it is contraindicated. It is not a routine. We can use it only in refractory shock. If the patient has AF, we have to do acute rate control of AF, either using beta blockers if the patient is not in hypotension or heart failure. We do this if the patient in the presence of concomitant acute heart failure, but no hypotension still. But if the patient is in severe heart failure, acute heart failure, or hypotension, we can use intravenous digitalis only for rate control, and this class 2A. Cardioversion for AF if the patient is unstable, as we all know. Amiodarone is very important, and it decreases the risk for early recurrence of AF after electrical cardioversion. So after electrocardioversion, use amiodarone still to prevent the recurrence. And in patients with documented de novo AF during the acute phase of STEMI, long-term anticoagulation should be considered depending on the SHAD score or SHAD-VAS score, as we all know, for the scoring of the probability of stroke and vascular accidents score. So if this is high SHAD score and if the patient is documented and new AF still there, is not improving in less than 48 hours or for more for 2 days or 48 hours, we can start anticoagulation or treatment doses of anticoagulation as treatment doses of tinzaparin or enoxaparin. Digoxin is ineffective in conversion of AF. It's only for rate control in severe heart failure or decompensation. Calcium channel blockers, beta blockers, including sotalol, are ineffective in the conversion, and the prophylactic treatment with antiarrhythmic medications, prophylaxis is not indicated. Only when AF happens, we should use the medications. So what's the management of the ventricular arrhythmias? Management of ventricular arrhythmias and the conduction disturbances in these patients. Intravenous beta blockers for patients with polymorphic VTAC or VF are less contraindicated. Prompt and complete revascularization is the best treatment. Intravenous amiodarone recommended for polymorphic VT, and the correction of electrolytes, magnesium and the potassium are very important for these patients. Also, in the management of ventricular arrhythmias and the conduction, in cases of there is sinus bradycardia, you can or hemodynamic intolerance or high degree AV block with unstable escape rhythms, you can use IV positive chronotropic medications such as epinephrine, vasopressin, and or atropine is indicated, or temporary pacing or urgent angiography for revascularization, which is the ultimate solution for these patients. And if the patient has recurrent VTAC, consider amiodarone, and the transcatheter pacing termination or overriding pacing should be considered if this VTAC cannot be controlled by repetitive electrocardioversion. So we should go to cath lab and do transvenous catheter pacing or overriding, or radiofrequency catheter ablation with ICD implantation, which is the final solution in patients with persistent recurrent VT and VTAC, VF with optimal medical therapy, which is not working or not reverting these patients to sinus rhythm. The ICD therapy is very important. So if these patients, after all this, is still a NIHA class 2 to 3 with low ejection fraction less than 35%, you can put an ICD despite optimal therapy for more than 3 months and at least 6 weeks after MI, who are expected to survive for 1 year, we can use the ICD implantation in these patients. Then it is very important that there, as we mentioned before, there is obstructive lesions causing the MI, and this is non-obstructive lesions. So if there is non-obstructive lesions, which is called the MINOCA, or non-obstructive causes for myocardial infarctions, this is usually diagnosed when the patient has manifestation, but if we do the angio, there is no manifest occlusion, or occlusion is less than 50% of the diameter of the vessel. So this is universal MI criteria present, but non-obstructive lesions and no clinical overt specific cause for the presentation, and this is called MINOCA. And we should go through a certain flow chart for these patients. We're doing an echo, angiograms to diagnose, and then exclude other causes like myocarditis, coronary epicardial myovascular lesions with echo or intravascular ultrasound, or myocardial disease with echo, or CMR, which is the cardiac MR. pulmonary embolism, such as CT angio or the dimers, and oxygen supply demand imbalance, which happens in type 2 MI, as we said before, in the type 2. This is all the Minoka thing. And last thing is the ongoing trials for any other intervention in addition to the PCI or the fibrinolysis. Yes, it is the mechanical devices or mechanical circulatory devices. Ongoing trials still, Anchor, Danger, ECMO, CS, and these all trials are either using VE ECMO plus intra-aortic balloon pump, Impella, or VE ECMO or ECMO plus renal replacement therapy, or ECLS plus PCI, VE ECMO plus PCI, ECMO that plus hypothermia, balloon pump. All these are Impella plus ECMO, for example. All these are ongoing trials and have to wait for the results. And how are they going to add to the PCI? These are the first the patients with the non-ST now. So we moved from ST elevation to non-ST elevation, acute coronary syndrome. So this is a simple flow chart for these patients. So symptom onset, the first medical contact, as we said, FMC. We can do NSTE diagnosis, and then if you can go to a PCI center, well and good. If not, we'll see what's going to happen. So if a PCI center, we do risk stratification. If there is very high risk, you should go for immediate invasive PCI in less than 2 hours. So how are we going to say that this patient is very high risk? Hemodynamically unstable, cardiogenic shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complications, acute heart failure related to this condition, and all of this, if any of this is present, can say that this patient is a very high risk. So the other thing, if this patient is only high risk, in high risk, should go all not for immediate invasive, but early invasive. So not less than 2 hours, less than 24 hours. In less than 24 hours, you should have early invasive PCI. And this high risk is established in STEMI diagnosis, dynamic new or presumably new contiguous ST-ST segment changes, resuscitated cardiac arrest. This is and the GRACE risk score more than 140. These are the very high and the high indications for the early invasive. If this patient hasn't any of these risk factors, he shouldn't go for this invasive intervention. If he presents to non-PCI or EMS with very high criteria, transfer him to a PCI center. High, same day transfer. Low, no transfer, and selective invasive when he is scheduled for. And this are the important thing with these patients. And this is the management strategy for this non-ST segment elevation in the most recent guidelines 2020 European Society. So you should do initial evaluation and pathway, monitoring and discharge. So assess symptoms, vital signs, ECG, and high sensitivity cardiac troponin. So this is very important. The high sensitivity cardiac troponin now is used because it has higher sensitivity, early presentation, and can be followed up at 0, 1, 3, 2 or 3 hours with very good results and interventions based on these results. So according to this, we do non-invasive imaging or high sensitivity changes within 1 hour, so we can triage this patient to CCU, ward, or observation, or discharge. Always consider now in new guidelines the BMP or the pro-BMP natriuretic factors. and always consider the stratification with grace risk score, because this is very important in the prognosis later on. After that, we go for the diagnosis, validation, and risk assessment with the clinical history, ECG, physical findings, laboratory findings, and additional ECG if recurrent, or additional leads to diagnose the ongoing ischemia, such as posterior ischemia, or right-sided leads to diagnose the right leads or the posterior area related to the circumflex. And with this, we have the high sensitivity at 1 hour as well, and continuous rhythm monitoring after that. What's the choice of the antithrombotic management? Aspirin and fondaparinux, okay? And or unfractionated heparin, enoxaparin, or bivalirudin. So aspirin in addition to any one of these medications. P2 Y12 receptor inhibitors, as in addition to the aspirin. Prasugrel, as we said, ticagrelor are better than clopidogrel, which is still there, and the carfentanil at the time of PCI because it has an IV route, and tirofiban at time of PCI as well because it can be given as an IV route. With this, they have invasive versus the selective invasive strategy and timing with ECG, vital signs, murmurs, grace risk, high risk score for immediate invasive less than 2 hours or early invasive less than 2 hours. And then we use the always the PCI is in favor of PCI or favoring in CABG. How we can favor PCI in single vessel disease or clinical instability, and favor the CABG in diabetes with complex multi-vessel disease, as we all know. Right ventricular infarction, don't miss that, because we are the clinical features of marked elevation of GVP, and usually clear lungs, low or normal wedge pressures are the important landmarks. And these are the ECG leads and its correlation. So inferior leads, anterolateral, through posterior, septal, anterolateral, infralateral, right ventricular leads. So you should always know the correlation between the leads and the area of infarction. This is the past thing, as we used previously CK and CKMB, which are early biomarkers, and troponin is a little bit later, but the high sensitivity troponin is early and we can rely on it now. And the new guidelines doesn't mention the CKMB or CK with this high sensitivity troponin. This is the two types of troponin I, which we use usually in this cardiac patient, troponin C and troponin T. I means inhibition of myosin and actin combination. This is the grace risk scoring. It's very important for stratification of patients and categorization as high risk, intermediate risk, or low risk. And this is another score, which is the TIMI or thrombolysis in myocardial infarction score. We have forced troponin elevation in myocarditis following cardiac surgery, trauma, sepsis, renal insufficiency, massive PE, and a very important role of the echo in ACS. So echo presentations may precede even the ECG, may even precede the biomarkers. Detects early regional wall motion abnormalities and loss of wall thickening, which often precede the overt ECG changes. We can diagnose ischemia from echo when we are lost and we don't know if this patient is in ACS or not. We should know and remember that NSTEMI is not benign, because there is still a high mortality rate, like 10% after the occurrence of NSTEMI. Not like STEMI, but NSTEMI is not always benign. What are the strategies? Fibrinolysis, PCI, and the CABG, and we mentioned the indications for each. All will know the indications, contraindications for the fibrinolysis, absolute, like hemorrhage, stroke, CVAs, intracranial neoplasms, active internal bleeding, 2 weeks, and aortic dissection known or suspected. And there are lots of relative contraindications for prophylaxis, such as severe hypertension, oral anticoagulation, INR more than 2.5, recent trauma, and traumatic CPR, peptic ulcer, active pregnancy, recent streptokinase, history of POCVA, and the chronic hypertension. What are the complications? Arrhythmias, post-infarcting angina and infarct extension, systemic embolization, hemodynamic instability, ventricular fluid rupture, ventricular septal rupture, acute myocardial regurgitation, and the cardiogenic shock and right ventricular infarction. We should always search for complications if the patient remains unstable after a successful intervention. Usually, and you should always search for a complication. If there's a VSD, is the rupture of one of the papillary muscles and acute MR, for example, a pericardial effusion later on, and maybe early or late. So we have lots of complications and lots of things to search for if the patient remains unstable. We can use inotropes for these patients if they are in pulmonary edema or heart failure, such as dobutamine, selective beta-1 receptor agonist, and it is usually inodilator, so inotropic, and it doesn't increase the afterload, so it is one of the best. We can use adrenaline, but the drawback of adrenaline is the alpha stimulation, and it may increase the afterload and not only the inotropic effect. Melatonin is one of the best for these patients, but it has always the disadvantage of vasodilatation and hypotension, and we might use some vasopressin or noradrenaline to decrease the side effect of melatonin, which is the hypotension. It is a phosphodiesterase inhibitor 5, as we all know. Levosimendan is increasing in popularity in some centers and in some countries. It's a calcium sensitizer, is inodilator as well, so inotropic, and decreases the afterload, and has a long duration of action, a long half-life, almost a week of half-life, so we can use it especially in cardiogenic shock or acute heart failure. Intra-aortic balloon pump, it can be used to augment the therapy, as it decreases the afterload and increases the coronary perfusion as well. These are different types of drugs that we already mentioned and the mechanisms of action. So the last thing that I should go through is this is the acute coronary syndrome in the COVID-19 patients. Lots and lots of things that happen with this COVID-19 era. So the SARS-CoV-2 virus attacks mainly the endothelial cells, and it anchors on the transmembrane angiotensin converting enzyme 2, and attacking endothelial cells, pericytes, and pneumocytes type 2, myocardial cells, and the induces this cytokine storm, as we all know, with interleukins. And with this endothelial damage in the microvessels, macrovessels, it might affect the acute coronary, it might cause acute coronary syndrome. And with this cytokine storm, it causes plaque instability and rupture. And with this affection of the myocardium, it causes myocarditis and myocardial dysfunction, arrhythmias, and the heart failure. All this is the pathogenesis. Very important is the algorithm for these patients triaging. So if you have a patient with suspected COVID-19, you should go to a COVID-19 hospital, equipped hospital with for these patients. And usually, if this patient is suspected, you should be treated as a positive until proved otherwise, or until he have a negative swab. So if you have a patient with out-of-hospital cardiac arrest now coming directly to cath lab, all the patients should be in PPE, all the toys, the medical staff should be in full PPE when they deal with this patient. And we should always apply the rules of intubation for COVID patients, using the filters and using the clamps and glidoscopes and these things for dealing with out-of-hospital cardiac arrests which are having low Glasgow Coma Scale and needs intubation. So you triage these patients, you put them in COVID-19 hospitals that can deal with them, and immediately after receiving these patients, an immediate swab, nasal swab or nasopharyngeal swab, or if the patient is intubated, take a swab from the endotracheal tube, which has a better sensitivity and specificity as well, and send it immediately, because dealing with the patient, putting a stent in, and finishing the procedure will take some time. After that, you should have a result for your swab, which can direct you if this patient should go to the ICU in a cubicle with negative pressure and full PPE, or should go to a COVID area, or can go to clean area with clean patients. This is very important, and we should always focus on these patients and deal with them as positive until proved otherwise. And this is one last figure here with the patients in COVID with high, if they have high troponin C levels, they always have high mortality with these patients, and compared to the blue line with these are patients without high troponin I levels, which have low mortality levels. Thank you very much, and I hope I wasn't, it was not too long presentation. Thank you so much.
Perfect, Dr. Amr, as usual, and very comprehensive. I will actually start one question from attendees in the COVID, the thing that you finished with. It's a quick question. He is asking, it's Dr. Yasser, and he is asking if there is any, what's the effect of increased serum ferritin levels in COVID-19 patients at heart? And do you think it can cause an acute myocardial infarction or acute myocarditis? And what's the role of iron chelating agents for treatment in that regard? It's kind of very specific question, yeah. And it looks like Dr. Yasser is interested in this topic in particular.
Sure. Our great professor, Dr. Yasser, the ferritin is considered as one of the inflammatory markers. So as I mentioned, high ferritin levels is indicating a very high inflammatory response, with the indicating an inflammatory or a cytokine or inflammatory storm as well, which we said it can make these patients more liable to plaque rupture if they are already risk factors. And they can increase the incidence of ACS in these patients. But in terms of the iron chelating agents, I have no experience with it.
I think there was few studies, all the studies talking about correlation between serum ferritin levels, but it was never a causation relationship, if you know what I mean. So correlation does not mean causation. It was never accused to be one of the causes of MI. I think it's the same, and it still applies to the COVID-19 and the impact on myocardial infarction. I don't know if you agree with me.
As in the guidelines, it states only the cytokines, mainly interleukin 6 and other interleukins, but it didn't mention the ferritin. Yes.
Perfect. Okay, so the next question here is from Muhammad Fuad. What about intraoperative management of myocardial infarction? Can we use non-steroidal anti-inflammatory drugs instead of aspirin? And can we use the fentanyl instead of morphine?
We can use the fentanyl, it's all right, but usually we should use the aspirin or the platelets, the anti-COX medications, the aspirin, and not the non-steroidal anti-inflammatory medications.
And I believe there is an IV aspirin as well, and you can put a nasogastric tube to give the aspirin by nasogastric tube. But like as a last resort, if it's gastric surgery or GI surgery, you still can give it as an IV, I think.
There is still IV present, but you can put an NG very easy and give the medications.
Islam Farhat is asking about what is the Takotsubo cardiomyopathy?
This Takotsubo is a kind of the Takotsubo in Japanese, I think it means octopus, and it is related to patients with severe anxiety or stress, and they present in heart failure with high troponin levels, and the picture mimicking a STEMI with heart failure and dilatation. So it's called Takotsubo because it's like an octopus. The LV is dilated especially in the apical part, so it looks like an octopus. That's why it's called Takotsubo cardiomyopathy. And it's usually the management is conservative and supportive for these patients. There is a good chance of recovery with the usual heart failure management, but it's always very important if you are going to anesthetize a patient with this syndrome, or that he has this syndrome. Usually you should have a very good pre-medication, very good assurance, and a very good relation with the patient, pre-operatively assessment, another echo, ECG, all the recovery picture should be there before inducing him again. And some of these patients, we may induce him on or put him on dexmedetomidine, for example, as a pre-medication, and then induce him. So it's a very important if you are coming through intubation or anesthetizing a patient with a history of Takotsubo. And it's very important as well because it also occurs intraoperative. So we can anesthetize a patient with unknown history of any cardiac condition, and immediately after induction and intubation, we have full fulminant picture of myocardial dysfunction and the pulmonary edema, and it's very stressful for the anesthetist and should go through a procedure of exclusion of everything until at last this is Takotsubo thing can be shown in the echo of the patient.
Okay, so the next question is from Marwa Hosni. If there is any difference between the management of pericarditis post-myocardial infarction and pericarditis from other etiologies, what will be the difference?
So if this, it's always of the effusion is the serial echoes that you do about this myocarditis and the treatment of pain, treatment of inflammation, and the need of steroids, and the follow-up echoes, and if there is a need for a drainage of any pericardial effusion, it should be done.
Okay, so the next question, synchronized cardioversion is not recommended with AFib in case of acute coronary syndrome. If it is a chronic AFib, what is your recommendation? So a chronic AFib and patient is going like to fast on top of that chronic and he is in acute coronary syndrome.
No, if any patient is chronic, known chronic atrial fibrillation patient, you should not attempt to synchronize this patient if he is hemodynamically stable. You should not, and you should always give the loading dose of amiodarone and then maintenance dose of amiodarone for these patients. Before this, always search for the electrolytes, magnesium and the potassium for these patients. If you correct the electrolytes, most of these patients can revert back to a low rate AF or controlled AF without the need for the amiodarone. But if needed, you should give the amiodarone bolus and the infusion rate afterwards until you have a rate control. If you have a rate control, you should be able to put these patients back, if he's stable, back on his beta blockers regimen that actually do the rate control for these patients.
Okay, so we'll end with Alauddin Ghanem question. What is the role of PCI in the treatment of type 2 myocardial infarction?
So it's always the PCI, as we mentioned, has guidelines in its use, and you always should use this PCI patient in patients with is either STEMI, or if this patient has NSTEMI, he should have uh, 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 any decompensation or any high risk factors, as we did with the GRACE scores and the other scores. So if this patient has high risk factors and he's symptomatic, not improving, he can go for a PCI.
Perfect. There's four more questions, Dr. Amr, just for sake of time and closure of this session. If you can, if you get 5 minutes to answer in short writing.